tripod. All right, guys. So this is going to be, I aim for this to be like a half hour-ish. Maybe I'll be quicker than that and can just answer questions if there are any. But this was meant to be a little update kind of trends that I'm seeing in QA over the last however many months that we've been doing things like this now that I wanted to kind of get across to everybody at our gathering of everyone. So this is just, again, a few of the things that I've seen across multiple bases, multiple crews that I felt like maybe I should just kind of readdress with everybody. So it's not any one in particular, it's for the whole service, obviously. So I'm going to talk about 4 main different things real quick. It's just kind of quick reviews of kind of the big one that probably doesn't surprise any of y'all, given the fact that this is what kind of the first thing I talk about with the Pearls email every month is kind of RSI and preventing hypotension and hypoxia, just trying to improve our numbers in that regard. Then a little bit about vent settings as far as kind of ventilation versus oxygenation parameters and like which settings affect which side of those things. Vent settings, we'll talk a little bit about AC mode because believe it or not, they're actually starting to recommend that we shift towards using more AC than SIMV. I'll talk about that briefly. And both of those things, kind of vent settings. Oh, you screwed it up.
I did screw it up.
All right, see, should have done it. Oh well, it'll work. The vent setting things, I know Johnny Coward's going to talk about them in a lot more detail. I'll give you kind of a quick little summary of what my thoughts are there, and then more to come later. And then from the request of a crew asking me about using the ultrasound for lung sliding and kind of are there any situations in which it might give you a false answer, and that is definitely true, so we'll talk about that a little bit. As well as something I didn't put on there was about how to look for B lines just real quick on the ultrasound. But so first off, starting with RSI, these are kind of the goals that I'm aiming for from a QA perspective, just so that everybody's on the same page about what I'm hoping us to get to. And they're in the order, the 3 main bullets are in the order of preference of how much I worry about it, how much I care. So the biggest thing to me is trying to prevent any new hypotension or new hypoxia as a result of our intubation. And my goal there is for that to happen less than 10%. When I'm looking at all the charts, I consider new hypoxia is they were greater than 90% before the intubation, and they went down to less than 90% afterwards. I consider new hypotension too. They were greater than 90 before, systolic greater than 90 before, and they went down to less than 90 after. Usually within about 10 minutes. It kind of varies a little bit based on when y'all time the intubation is happening versus when the exact times that the vitals are coming across, our 2 5-minute vitals, but roughly 10 minutes after intubation is kind of the numbers that I'm using. Then after that, first pass success rate, preferably over 90%, and then the third one, overall success, preferably over 95. You'll see some of the various national groups like the gamut metrics that we kind of try to follow. Sometimes some of those things like first pass success, they're going to tell you that they want it to happen 100% of the time. I'm more realistic than that. We can't pull anything off 100% of the time. That's why my numbers are less than 10% on the hypertension, hypoxia, and greater than 90, greater than 95. Again, I'll mention those are in my order of priority. And the most important one to me is the hypotension, hypoxia. If you need to abandon your first attempt in order to prevent them from getting hypoxic and back them up a little bit and go up, obviously your first pass success is going to go down, but to me the hypotension, hypoxia is the important part. So talking about that a little bit, kind of preventing hypoxia. First off, the biggest thing is pre-oxygenation. And one thing I want to stress, despite everything that's up there on the screen, is obviously each patient is a little bit different. Some people are way easier to oxygenate than others, so you don't necessarily have to do max pre-ox every time. If you've got somebody on the nasal cannula and they're in the high 90s and you're not worried about it, then cool, that's plenty. When I'm keeping track of this on my RSI sheet, this column is appropriate pre-ox is what I call it, and if it seems like if you were able to pull it off with the nasal cannula and nothing went wrong, then great. What I consider to be maximum pre-oxygenation is using a BVM with a PEEP valve, nasal cannula on under the BVM, running at full blast in preparation for your apneic oxygenation, and then either an NPA or an OPA, whatever they can tolerate. All of those together are kind of the maximum best version of pre-oxygenation that we can pull off in an aircraft. So basically, and then abort your attempt if you're getting down into the low 90s. I say low 90s as opposed to 90 because as we've all heard, for the most part, what you're seeing on the monitor is a good 15-30 seconds behind what's actually happening to the patient. And then that 90% cutoff is where it kind of starts to fall real fast on all those charts that we've all seen in the textbooks. So I personally try and stop at around 91, 92, because I figured the patient's probably already at 90, even though I don't see it on the monitor yet, and they're about to crash a lot or go down a lot faster. So again, let me stress again, you don't necessarily have to do max pre-ox on every patient. So like if somebody is doing great, then everything, and nasal cannula or your BVM, or excuse me, your non-rebreather is working fine, then don't necessarily need to worry about this stuff. But if you've got a patient who's not doing so hot, who's particularly anybody who's already less than 90 before you start the intubation, I would like to see all this stuff attempted before jumping straight into intubating. And again, everything I say today, like I already said about the goals yesterday, I know that none of this is 100%, that we can't perfectly figure out every situation and apply one rule 100% of the time. So sometimes there are going to be exceptions to the rule where it just needs to happen now, even though they're already under 90%. But most of the time, if you don't have adequate pre-ox, I want you to try your best to get it done. And then if the numbered marks fall and it goes down less than 90%, but you tried everything that you could possibly try, I'm not going to ding you. That's adequate pre-oxygenation if you tried everything but it didn't work, because it's not always going to work. Any questions there? No? Okay, so moving on, similar deal, preventing hypotension. The biggest thing here, kind of in recent times, particularly in trauma and like the newest version of ATLS and everything, is they're really trying to push resuscitate before you intubate as a real philosophy. Trauma patients are a great example for that, because they're usually hypotensive because of their injury, because of a bunch of bleeding, and their airway, despite the fact that they do need it protected because they're zonked out and probably aren't doing a great job. And if there were to be any sort of serious secretions or vomiting or whatnot, then they would have trouble with their airway. But while they're sitting there right in front of you right now, their airway is actually relatively okay. They might even still be breathing all right. If you've got time to be able to try and give your 1 to 2 liters, interestingly, the most recent version of ATLS, the 10th edition that just came out, they're saying stop at 1 liter now. So like a little bit of fluids, that's not working, moving to blood products, that sort of stuff. If you've got time to try and do that stuff and get their blood pressure up a little bit before you give them their meds, then do it. That goes with medical patients too. The medical patients are a little harder, because if the problem is an airway / breathing problem, it may be a little bit harder to try and resuscitate before you intubate. But really kind of stop and take a couple of seconds to think of, can I work on the blood pressure a little bit before putting the tube down, or does the tube need to go down now? If the tube needs to go down now, then do what you got to do. If you've got some time, try and resuscitate them a little bit. Consider push-dose pressors. We've been talking about this for a while now. The two biggest situations when I want y'all to think about it are shock index is an important number to remember. There's been some studies talking about it. The most, kind of the highest quality of one that we have discussed a few times is one where they were used 0.9 as a cutoff, and where anybody greater than 0.9 after they did the data had a much higher risk of becoming severely hypotensive after the meds were given. And the shock index is a real easy number to figure out. It's simply the heart rate divided by the systolic blood pressure. And so a quick, really easy, on scene, don't need to do any math way of figuring this out is, instead of saying 0.9, just kind of bump that up to 1. And that becomes really easy to just say, if their heart rate is higher than their systolic blood pressure, then you need to be a little worried about what's going to happen after they get drugs, and consider going ahead and giving the push dose. I'd say probably go ahead and do it. But even if their shock index isn't all that high, even if they're just borderline low, like they're sitting in the 90s, but their heart rate is still in the 80s for some reason, maybe they're on beta blockers, maybe for all hosts of reasons why their heart rate might not be low. Just be cautious about anybody who's got a tenuous blood pressure before you're starting to give major meds in order for an intubation. They're high risk of those meds causing their pressure to drop. Another one is if they are low, borderline low, or in a situation where you're worried about their pressure dropping, is consider halving your dose of the sedative, which is actually not expressly stated in our current guidelines, but it's still in there. You know, there's 2 different boxes on our current RSI guideline for normotensive versus hypotensive patient. If you look at the doses that I put in there, the ones in the hypotensive box are half of the ones that are in the normotensive box. And so for, say, ketamine being one of our most commonly used ones, I usually say in normotensive, you can give anywhere from 1 to 2 mg per kg of ketamine, but in the hypotensive box, I'm pretty solidly say you should stick to 1, maybe even a little less than 1. Etomidate, for example, is 0.3 if they're normotensive, drop it down to 0.15 if they're hypotensive or at risk. That's another good way to try and prevent any hypotension from happening. And once again, I'll stress again, if you've done all the best stuff, if you're in these situations and you thought about it and you gave a push dose and you halved your sedative, or maybe you didn't give a push dose but you put in there a reason why things were kind of needing to move faster, if you showed that you were thinking about all this stuff and doing your best to prevent it from happening, then I'm not going to ding you for it. It's because it's never going to work 100% of the time. But I want to see that this was thought about, that y'all were thinking of it, and that you tried to prevent anything from happening. Does that make sense?
So if you got somebody with a borderline blood pressure, I think that's probably the biggest decision, you know, we're having to try to make is how aggressive.
Yeah.
And when to make that, maybe. So if you got somebody's got a blood pressure of 100 over 60, their heart rate's 80. You know, are we going to be scrutinized for going ahead and maybe trying a little bit of half dose,
No.
40 nights of neosynephrine, or, you know, a little bit of epinephrine or something like that to pop that pressure up before we intubate?
No, particularly if something like, if somebody's on the fence and like kind of what different people consider to be on the fence about is getting kind of close to low, varies from person to person, honestly varies from clinician to clinician. I would say somebody sitting right at 100, I would be a little worried about them too. So I would say I would err on the side of caution. I would think giving somebody a relatively small amount of phenylephrine or epinephrine, et cetera, in an effort to be cautious is going to cause less harm in the long run than our hypotension numbers being high, because we know hypotension is a problem.
Okay.
Any other thoughts there, questions? No, no.
Why the ketamine in half if it's gonna help the blood pressure?
So ketamine does, you can jump in.
Yeah, we've been doing a lot
just
of research on that. Ketamine is showing that with a stroke index of 0.9, a stroke shock index 0.9, that patient is at the point they're probably catecholamine depleted, and by giving the ketamine at the full dose, you're going to suppress the myocardium, because you're going to suppress the sodium flux into the myocardium during the RSI, and you will get a drop in blood pressure.
So you're already past the point
You know,
anyways.
yeah,
Okay.
that was a new thing to me, because I was, catecholamines, give it, blood pressure goes
Yeah.
up, we're good to go, and then some of the studies now are showing.
So that's,
And that was something we're gonna talk about on the other side too,
He's gonna talk about that more.
More about drugs and have a
Um,
discussion about the drugs more than.
but that study where they used 0.9 as their cutoff was a study using ketamine.
Okay,
So ketamine, even though it is well touted as being something that's great for people that are hypotensive, that's why we often recommend using it with our hypotensive patients. It has been shown, certainly not every time, because as we've all heard, a lot of times it'll help their blood pressure, and that's why we're saying use it, but it's not immune from having issues like this too. The kind of brief summary of what he said, and kind of slightly simpler summary of what he said is if ketamine works partially by stimulating the sympathetic nervous system, and if you've already used all of your sympathetic neurotransmitters, it doesn't have anything else to give. And so it can still happen with ketamine. Just be wary. It can happen with any of these drugs, even the ones that are supposed to be cardiovascular protective or less hemodynamic effects from it. It can still happen with any of them. So just be cautious. All right, moving on from there. Vent settings. One thing that this was harped on me in my residency, and is something that I want to pass on to you guys. When you're thinking about the ventilator settings and the 4 main things that we usually do, the tidal volume, the respiratory rate, the FiO2, and the PEEP, plus a bunch of other extra settings, but those are your primary 4 settings, right? Plus, and mode, deciding what mode you're on, obviously. Of those 4 main settings, tidal volume and respiratory rate are your ventilation parameters. That's what's going to affect your CO2. FiO2 and PEEP are your oxygenation parameters. That's what's going to affect your oxygenation. I don't believe in any 100% in medicine, as we've already said a couple of times, so I'm not going to tell you that it's not possible for one to affect the other outside of those categories, but for the most part, changing the oxygenation parameters isn't going to do anything to fix your CO2, and changing the ventilation parameters isn't going to do anything to fix your oxygenation. So our crews, it's like the trend that I'm seeing where I wanted to bring this up is not so much a CO2 problem. For the most part, everybody seems to reach towards either changing the tidal volume or changing the respiratory rate when you're trying to fix the CO2, be it from an ABG or an end-tidal. What I have seen multiple times is somebody with low sats, and the crew's attempt to fix the low sats is to change the tidal volume or the respiratory rate, which is really not gonna do much. So that's just something that you need to remember. Like if you're trying to fix sats, it's gonna be FiO2 if it's not already at 100%, trying to go up on the PEEP as best as possible, or switch it, or trying a different mode, like maybe moving over to a pressure mode, or seeing if PRVC is gonna work, those sorts of things. And so that's really all I wanted to get across there. For the most part, even though nothing's 100%, kind of keep those separated in your head, where the FiO2 and the PEEP and all that aren't really gonna change your CO2. And vice versa, the respiratory rate and the tidal volume aren't really gonna change your sats. So there is, to some degree, there's a little bit more bleed over there, obviously, which is why people trying to do it. But I would say, for the most part, focus more on, with the sat problem, fixing FiO2, PEEP, or the mode that you're on. That's a really brief point. Any real questions there?
We're gonna do some scenarios.
Yeah.
With some of this stuff in it and kind of talk about it.
Moving a little bit more detail into the ventilation parameters, the other thing that I want to talk about is, I've talked to several of you about this more individually, and I felt like it was time to kind of bring it up to the whole program, is when you're setting your ventilation parameters, I want you to be thinking in your head more about minute ventilation than respiratory rate and tidal volume. Obviously, you need to figure those numbers out, because that's how you're going to set your minute ventilation, but the overall thing that you need to have in your head when you're trying to make CO2 changes and make your ventilation is respiratory rate and tidal volume, leading to minute ventilation. Minute ventilation is the key thing. So minute ventilation is simply your tidal volume times your respiratory rate. And what that comes out to, since tidal volume's in milliliters per minute, it's gonna be something like 7,000 or 8,000 or 10,000 or 12,000. Sometimes abbreviated when you're reading about this in the books as liters per minute, in which case they just say 7, 8, 10, 12, etc. But acidotic patients need a really high minute ventilation, because basically the more you're breathing, the more CO2 you're gonna be able to off gas. The less you're breathing, the less CO2 you're gonna be able to off gas. So if somebody's really acidotic, the more CO2 you can blow out is gonna decrease that acid burden, increase your pH. And so even if it's a metabolically acidotic patient, if you give them a high minute ventilation, that kind of helps them compensate for the acidosis. It's definitely not going to fix anything. The only thing that fixes metabolic acidosis is fixing whatever problem is causing it. But this is kind of helping us just keep their pH in a more not about to code on you range. And so this is kind of how vents can help with that. So for the most part, high minute ventilation, when I say high minute ventilation, an acidotic patient's gonna need a high minute ventilation. I'm talking about greater than 10 liters per minute, maybe even upwards of 12 to 14, kind of depending on the situation. So you don't be surprised if some of these patients end up in the low 30s. As long as you're not having like an obstructive issue, like a COPD or an asthma, and they're not having trouble exhaling, then breathing really fast isn't that big of a problem, particularly just in the acute phase. Once we get them into the hospital and try and fix things to a little bit better, things are gonna change. But while we're taking care of them acutely, it's not that bad to go up to pretty high numbers. I would say probably don't ever go higher than 35, maybe, like getting into the high 30s, low 40s in particular is gonna be too fast for really anything to happen within that ventilatory cycle. But so kind of low 30s though is not out of the question. But so for example, if you think about kind of some relatively standard settings that we might all not be all that surprised with, say like somebody on a tidal volume of 450 with a respiratory rate of 16, that's gonna be a minute ventilation of 8,000, assuming I remember the math that I did prior to this thing correctly. So what I want you to remember there then is think about minute ventilation, and it's like if somebody who's sitting on those settings has like a really high CO2 and you're trying to off gas more CO2, you want in your head to think, I need to raise his minute ventilation, not so much I need to change his tidal volume thing, which you're gonna probably change the tidal volume or the respiratory rate to pull that off, but think about the minute ventilation. And the example I wanna give you is using those same settings, 16 and 450. If you say, oh goodness, his CO2 is going high, I need to blow off some gas, so I'm gonna raise up his tidal volume to 500. It's not uncommon across the surface that I see people say, all right, we're gonna raise the tidal volume to 500, but because I raised that, I'm gonna drop the respiratory rate to compensate. So if you go from 500 or 450 to 500, and then even just drop the respiratory rate from I say 450 and
16.
Okay, so sorry, 450 and, sorry, I see I screwed up the math that I did before. Say like 450 and 20 is gonna be a minute ventilation of,
9 liters. It'll be 9 liters, 9,000.
yeah. So, I'm gonna do this in mind. Make sure I'm telling you the right numbers to give you the right example. Oh no, you're using my phone to record me doing this.
I got my.
Yeah, and then if you go to 20.
So if you take somebody
Into
from 450 and
516.
20, so 450 times 20, whoa, 450 times 20 equals, your thing is messing up, 450 times, there, 9,000. So if you take somebody up to 500 and then drop their rate just down to 18, 500 times 18 is still 9,000. You didn't change anything. And if you even go further than that and say that I'm gonna go up 500 and drop them down to 16, then you've gone down to 8,000, you've made it worse, even though you raised the tidal volume. So I want you to think about that minute ventilation when you're trying to fix these things. You need to raise the minute ventilation.
Drop the tidal volume and increase your rate?
It depends on the situation. In most cases, yes, you're gonna wanna change your rate because of everything we've learned from ARDSNet and even outside of ARDSNet, how low tidal volume ventilation is protected for patients in the acute phase. For the most part, what I like to do, what I've taught some of y'all to do as well already, is think about in your head, what's a rough minute ventilation that I'm gonna need? Like say this is a fast patient, maybe I usually start at 10 liters per minute and then titrate from there. Let's start at 10, figure out what's his ideal body weight, what tidal volume do I need? Okay, I need my tidal volume to be 450. Then take 10,000, divide it by 450, and that answer will be the respiratory rate you need to put him on. And then from there, you can move up and down on the respiratory rate, but once again, just remember kind of, as long as you're just changing one and not changing both, then an increase in one is gonna increase your minute ventilation, or a decrease is gonna decrease. It's when you start changing both that you really need to kind of do the math and make sure you're making a positive change as opposed to screwing things up. Does that make sense? I think you're gonna go over that a little bit more maybe, but.
They're running back right
Yeah.
now.
So any questions there before we move a little further? Cause I'm already,
Oh, you're good.
we're already 11:30. I'm competing with lunch and I know that's a bad thing to do.
Lunch will always win.
Lunch will always win. All right, so then we'll move on. The last topic is not too terribly long. Oh wait, sorry, I almost forgot about this one. So real quick, we're probably gonna start moving towards using more AC than SIMV. This is something that came to us from the respiratory therapists originally. Johnny was talking to the respiratory therapist and they said that this is what they were starting to do in the hospital, and we started asking questions like why? I don't really understand. And then I emailed one of our intensivists and asked him about it. Apparently there have been some studies relatively far back now that showed that SIMV is harder to wean. People usually end up in the ICU longer when they've been on SIMV. It's harder to get them back off of it. And the other problems that he mentioned is some more local data that he's got. I don't know if he's published it, where the SIMV, the spontaneous breaths that they bring in that are just pressure supported, often end up being way over 8 cc's per kilogram. You know, they often end up giving themselves too much air when they're taking in their spontaneous breaths. And then it's also can lead to some vent dysynchrony issues because it's the varying tidal volumes leaves the body not really sure what the heck's going on. It's like on some breaths I'm getting 450, on some breaths I'm getting 800 or whatever, and the body just like doesn't like that as much as it likes ever being on a ventilator. But
I just have a question.
Yeah.
So with the assist control,
Mhm.
knowing that that's just a set tidal volume now, patients are gonna sometimes be more uncomfortable. Are they having to use more paralytics in these patients?
So that's that. I asked him that exact same question. I was like, so one is like kind of which causes worse vent synchrony? This getting a bunch of different tidal volume breaths versus everybody being at low tidal volume, because patients don't like being at low tidal volume either, even though it's good for them. They're saying they in the hospital very much avoid using paralytics if at all possible, just like I've been trying to teach everybody around here, which is sedate as best as you can and then paralyze if you have to. He didn't say that they really have been having to use more paralytics, but he did say if you got to, you got to. He very much harped on appropriate sedation though. In particular, the ICU, the medical ICU side, more so than trauma, are really trying to steer away from using benzos, and they were talking about using like ketamine or propofol. Or not propofol, excuse me, ketamine or fentanyl actually. Like first line for us in the ER these days is put them on a fentanyl drip.
So
see if
those
that works.
patients are laying in a
Yeah, I know,
controlled
I know.
quiet environment
Believe me,
and with vibration, are you not gonna trigger breaths on assist control?
No more so than you would on SIMB, than what we're already doing.
And I've had that problem with SIMB. I've
we're gonna
had,
talk
But,
about
and
that.
remember, like that, this is getting more into
Hold on.
detail about the vent than we need to spend time on right now. We're gonna talk about it a little more later. Remember, you can change the sensitivity on
yeah,
the ventilator.
that's been my work.
So, but yes, still, it's the same. I mean, they're not gonna like being on low tidal volume, so you're gonna have to sedate as best you can before paralyzing if you have to. But definitely don't ever paralyze without having sedated. Even to the point of giving the drugs at nearly the same time, giving the paralytic before the sedative, even if the sedative followed right behind the paralytic. We've got people in other departments looking over our shoulder that have sent us several charts about that already, where they're just like, the paralytic was given first, even though the sedative was given a couple seconds later, they still
We just
give
mix them together.
Alright, so moving from there is real quick, lung ultrasound pneumothorax. These are the situations where you can get negative lung sliding, but it not be a pneumothorax. It is important to, thank you for asking me to go over this, to know. Somebody that's even just a severe COPD or asthma, like super duper duper severe, to the point that they're breath stacking a little bit, the lungs might just not be moving enough for you to tell that there's lung sliding because they're so over descended with air. That should really be kind of at the end course of breath stacking, but it can happen. Large blebs, if they've got such bad emphysema that they've got this giant little air pocket that doesn't work the same as the rest of the lung, it might cause abnormal lung sliding. If you right main stem somebody and you're checking on the left side, obviously they're not gonna have movement on the left side. That's just kind of being aware and doing appropriate airway confirmation. And then somebody who's got a history of any sort of pleurodesis or pneumonectomy is obviously gonna be abnormal. The most sensitive sign for pneumothorax is lung point. What lung point is if you can find the point on the ultrasound where the transition happens, where you see the point where absent lung sliding starts and normal lung sliding begins. I'm gonna try and show y'all a quick little video about it. Let's see if it works. Anybody remember what number I said on there? Was it 344?
344.
Max,
That
this
is
how
lung
you
point.
No air in between the visceral and the parietal pleura.
That's
Thereby
absent lung sliding.
excluding a pneumothorax.
That's
This
lung
is
point.
how you rule in a pneumothorax. This is called a lung point. Now what you're seeing with the lung point is you're seeing the interface between where the lung sliding is happening and where the absence of lung sliding is happening. This is the limit of the pneumothorax, and if you see this, you have a very high positive predictive value.
Does that make sense? I wanna see it again?
Yeah, one more time.
Anybody need to explain what's happening on the screen right there?
I do.
Okay. Remember when we talked about lung sliding in the first place? This is kind of the soft tissue of the chest wall. This big bright white line is the pleural lining. And then everything down here is lung, essentially. You're not actually seeing the lung because the ultrasound can't see lung. You're seeing a bunch of artifacts, but still, this is kind of where the lung is. The best way to identify the appropriate bright white line is to have like a rib here and a rib here, and you can see that white line running right between the back, both ribs, which he doesn't have in this picture. But once you've done a lot of them, you'll also just kind of start to recognize the pleural lining just cause. And so I think this, where I just backed it up to, is an example of absent lung sliding,
From the
where it's just not
visceral
sliding at
pleura.
all.
So if you can see B lines.
Right here.
It means that there's no air in between the.
He's talking
visceral
about
and the
B lines, but
parietal
ignore it for
pleura,
a second.
Thereby
This is-
excluding.
Now this is lung
pneumothorax.
point, so here's your line.
This is how you rule in a pneumothorax.
This is the patient
called
breathing,
lung
and you see
point.
this clearly
Now, what you're
different
seeing with the lung point
type
is
of
you're
lung
seeing
slide
the
into
interface
view as he
between
breathes,
where
and then
the
as he goes
lung
out, this
sliding
one
is
that doesn't
happening
seem like
and
it's
where the
moving at
absence of
all
lung sliding
is
happening.
just hanging out there.
This is the limit of the pneumothorax, and if you see this, you have a very high positive predictive value of seeing a pneumothorax.
So
And that's based on a degree of, here, we still have a fair bit on that side of inflated lung. I mean, you still have some that's working.
Yeah.
But if it's totally down, you're not getting anything.
exactly, if it's totally down, all you're gonna get is absent lung sliding, which based on clinical context, might still be a pneumothorax if we're talking about a 30-year-old trauma patient that shouldn't really have severe COPD, asthma, blebs, or any of that stuff, then it's probably a pneumothorax. 80-year-old nursing home patient may be a different story.
So what you're finding there is the point where the lung,
Yeah, the
where part of the
point.
lung's up, part of it's down.
Yeah, exactly.
And is that, in that point where it changes, that's right here?
Yeah.
Yeah, just show them what's looking at it.
Okay, so there's that. And now there's only one other thing that I wanted to tell y'all about real quick, just because this is not something that we directly talked about in ultrasound training, but it's something that's a good thing to know about and is really relatively easy to discuss real quick, is what B-lines are and what they mean. So seeing B-lines on a pulmonary ultrasound, like it doesn't even matter where you put the probe or which direction you put it in, just somewhere on the chest where you can see the lung, between the ribs down towards the lung. If you see B-lines, and I'll show you what they look like in a second, that refers to increased lung density, which can either be fluid or consolidation, but where it gets particularly helpful, particularly in our setting, is if you've got that multi-medical sick patient that has a history of both COPD and CHF, and they're having severe shortness of breath, and you're trying to figure out which one's the bigger problem right now. If you see a bunch of B lines, then that's probably, given the clinical context, a whole bunch of fluid in their lungs, and it's more of a CHF problem than a COPD problem, and it's something really quick and easy. It takes about as long as it does to get the ultrasound out and turn it on. You just put it on there and you can see it, and it's gonna look like this. As I've talked about them before in ultrasound training, the other thing that you may have heard me call them is comet tails. And before I even turn on the video, I'll show you that it's basically like really bright streaks of light running from that pleural lining down low towards the lung. Towards the lower parts of the lung. What number did it say?
248.
That's what it was.
This is Jacob Avila, and today
Jacob Avila.
only means fluid. So these right here are B lines I'm using in curve.
All these streaks of light that are
in the
coming down
intermuscle space, so
are
I'm
B lines.
transverse in between the ribs here. That's why it looks so wide and you can't really see ribs, because I'm actually in between the ribs. We like to think of B lines as being present cardiogenic pulmonary edema, and they definitely are, but they're
Does that make sense? So basically, if you see he's got some pictures back here where he diagrams it a little bit. I don't remember where they were. This is actually a really good video to just go watch. This website in general is a great one for learning about ultrasound stuff. It's from Jacob Avila. He was one of our residents here, and then he did an ultrasound fellowship at Kentucky, and then he came back and worked here again for a little while, and now he's back in Kentucky. But his website is 5 Minute Sono. He's got a bunch of little 5-minute videos about ultrasound tips. And so,
kind of bounce around it here.
again, we'll just say that essentially all these streaks, like kind of these streak artifact, and you can see them move as you're moving the probe and as the lungs are moving, you see these streaks move along with it. Essentially, if you want to get real technical about diagnosing pulmonary edema, you need to see 3 or more of these lines within your field, and I forget the exact numbers. I want to say it's at least 2 different areas of the lung on both sides. So if you can find it in 2 or 3 areas over here and 2 or 3 areas over here, then you've got diffuse edema. That's the technical definition. But even just a quick look of, man, that looks like there's a whole crap ton of fluid in this lung is worth kind of looking real quick if you're trying to figure out that COPD versus CHF thing.
Cool.
All right. That's it. That was my quick kind of pearls and overview. Now it's about time for lunch unless anybody has any questions. And again, some of that stuff, particularly the ventilator stuff, Johnny Coward's gonna go over in more detail this afternoon.
There's a form coming around, everybody needs to sign.